afternoon and good evening to all the speaker chairs and the wonderful audiences in different parts of the world. Welcome to the ACNS webinar. The speaker for the first session today is our honored guest from China, Professor Gu Xijin. Professor Xijin is an associate professor of the Department of Neurosurgery at Huashan Hospital, Fudan University, Shanghai. He is mainly engaged in clinical treatment and basic and clinical research in intracranial tumors, spinal cord diseases, and traumatic brain injury-related diseases. He has a proficient surgical skill and have accumulated rich experiences in the treatment of difficult and severe neurosurgical pathologies. He has been honored with several awards such as National Young Neurosurgeon Surgical Skill Competition and Rising Star of Medical Talent in Shanghai. He is a member of the following committee, which includes Spine and Spinal Cord Group of Neurosurgical Branch of the Chinese Medical Association, Spine and Spinal Cord Professional Group of the Neurosurgical Branches of the Chinese Medical Doctor Association, Spinal. We are extremely honored to have him today at our webinar, and he'll be talking about multidimensional exploration of spinal cord function and spinal stability protection strategy during the surgery. Our second speaker for today is our honored guest from the United States of America, Professor Joshua Bedison. Professor Bedison is the Leonard Mellis, Corinne and Joseph Graber Professor of Neurosurgery at Mount Sinai Health System. Is an expert skull-base and cerebrovascular surgeon with special interest in the treatment of complex intracranial and spinal pathology. At Mount Sinai, he established the first basic sciences laboratory in the Department of Neurosurgical, developed model of stroke and subarachnoid hemorrhage. He has also launched a book surgery stimulation program in 2012. He previously served as the president of the New York Society for the Neurosurgical and was the chair of the cerebrovascular section of the ACNS CNS. He is currently the chair of the American Heart Association Writing Group on subarachnoid hemorrhage. He was honored at the ACNS annual scientific meeting at the cerebrovascular section of Ghazi Yasage lecture. We are extremely honored to have him today at our webinar, and today he'll be talking about innovation in neurosurgery at the Mount Sinai Advanced Technology and Biology. Our chair for the first session today will be our honored guest from Pakistan, Professor Salman Sharif. Professor Sharif is the Chief of Neurosurgery at Liaquan National Hospital and Medical College, Institute of Postgraduate Studies and Medicine Sciences, Karachi, Pakistan. He is the co-chair Spinal Committee of the World Federation of Neurosurgery. He is the president of the World Spinal Column Society. He was the past president of the Pakistan Society of Neurosurgeons. He also an executive and education committee member of the ACNS and World Federation of Neurosurgery, and endoscopic committee member. He has been the torch bearer for online education for young neurosurgeons in his country. We are extremely grateful to him for accepting our invitation to chair the session of Professor Gu Xijin. And our chair for the second session today is our honored guest from Czech Republic, Professor Vladimir Benes. Professor Benes held the position of the head of neurosurgery in the Central Military Hospital Prague and chair of the Department of Neurosurgery in the First Medicine Faculty, Charles. He was the past vice president of the European Association of Neurosurgical Society, EANS, till 2007, and the chairman of the training committee of EANS, as well as the president of EANS. He was the previous head of the neuroanatomy committee of the World Federation of Neurosurgery, along with the Professor Imad Kanan. He's also invited faculty to various workshops and conferences organized all over the world. His literary contribution sum up to a score of published articles in various international journals and book chapters. We are extremely grateful for him to accepting our invitation to chair the session of Professor Bedison. And on behalf of the Education Committee of the ACNS and the President, Professor Yoko Kato, I would like to welcome both speakers and chairs and wonderful audiences to this online platform of ACNS webinar. A warm welcome to our colleague from China, and we're extremely thankful to Professor Zubin for broadcasting the webinar on the WeChat channel. With that introduction, may I hand over the podium to our first chair, Professor Salman Sharif. Professor, please.
It's really my pleasure, and I'm really looking forward to hearing this talk because I've heard so much about what's new in spine surgery in many parts of the world. and my dear friend Tu Shiksin, who's been doing a lot of interesting work in this field. And I'm looking forward to hearing from him. So it's really, I'm delighted that I'm here and listening to this talk. So Gu, please carry on.
Distinguished Chairman, dear Professor Selman, distinguished audience, dear everyone, good evening. I'm Gu Shixin from Shanghai Huashan Hospital, Fudan University. Today, I am very happy to have the opportunity to talk with you about how to protect the stability of the spine and the function of the spinal cord during the perioperative period. Before we get started, let's take a look at a case. This is an 85-year-old male patient presented with numbness and weakness of both lower limb for half a year. He has a recent history of cardiac stent implantation and is currently taking anticoagulants. MRI shows a very typical cervical spine stenosis from C2 to C6. The spinal cord is compressed and degenerated. For such an elderly patient with cardiovascular problem, how should we choose treatment? We envisioned the following surgical treatment options. My personal preference is the simplest and the most streamlined solution, the shortest operation time, the less trauma, and the quickest recovery of the patient from operation. Unfortunately, this patient did not choose me to operate. He went to another hospital. The patient's low limb muscle strength became significantly worse after the operation. This is the MRI after the operation. Let's not discuss whether the choice of surgical plan is reasonable for the time being. Complications after surgery are enough to ruin the rest of the patient's life. The purpose of citing this case is to illustrate that the first principle of our spinal cord surgery is that no matter what the situation is, we cannot aggravate the patient's symptoms. Many patients come here for tumor resection and some come here for functional disease. They have symptoms before surgery and their appeal is to improve their symptoms. So we cannot make the patient's symptoms worse anywhere. Therefore, how to protect the function of the spinal cord during the operation and how to protect the stability of the spine must always be the most important issue for us. So in my lecture today, I will sort out how to protect the patient's spinal cord function and the spine stability during the perioperative period from the following aspects. Some content may sound very basic and simple, but it is indeed some details that are often overlooked. First, let's talk about the choice of surgical approach and incision design. Let's look at a case first. This is an 8-year-old girl. We diagnosed a schwannoma inside and outside the spinal canal before surgery. We can see that the part of the tumor in the spinal canal has compressed the spinal cord, and the spinal cord is basically invisible. Please note that this part is not the spinal cord. It is a vertebral body. The spinal cord is so compressed that it cannot be seen. The tumor grows out of the spinal canal through the intervertebral foramen on one side. How do we formulate a surgical plan for such a little girl? Because this is a child, we strive for a short operation time and less trauma. At the same time, we need to solve his main problem, which is the decrease in muscle strength caused by the compression of the spinal cord. Therefore, the surgical plan we chose was to do the posterior approach in one stage and remove the tumor in the spinal canal. On the right, it is the MRI after the operation. We can see that the tumor in the spinal canal has been completely removed. and the spinal cord obviously recovered its shape. The girl's muscle strength returned to normal a few months later, but we can see a small tumor remained. But we did not rush to do the second stage operation. Instead, we sent the patient back for a follow-up. After 2 years of follow-up, the tumor outside the spinal canal has grown significantly, and there was no tumor recurrence in the spinal canal. So we performed a second operation on this girl. This time, we used an anterior approach to the neck, directly incising the skin of the neck, separating the muscles, and exposing the tumor. After two-stage surgery, both the tumor inside the spinal canal and the tumor outside the spinal canal were completely removed. This case shows that we need to choose the surgical approach flexibly according to the specific situation of the patient. Next, let's talk about the positioning before surgery. As we all know, whether it is brain surgery or spinal surgery, successful positioning means more than half of the success of the surgery. Let us first clarify a few basic concepts. Usually, we say which segment the tumor is located in is based on the positioning of the vertebral body, which is always the positioning reported by the radiology department. Many positioning makers during surgery are often positioned through the spinous process. The difference between the two should be familiar to us when we learn anatomy. We give an example to illustrate the process of preoperative positioning. This is an interesting case. This patient underwent a thoracic scope perivertebral schwannoma resection in the thoracic surgery department, and a CSF leak occurred after the operation. CSF flowed from the subarachnoid space into the thoracic cavity, and the patient had difficult breathing, and a closed thoracic drainage was used. The difficulty of this surgery is how to accurately locate the fistula before surgery first. We have to analyze the MRI image very carefully, and we cannot blindly trust the report. We take the following approach. We performed cross-comparison of coronal, transverse, and sagittal images on the computer to determine that the fistula was located on the right P10 to 11 intervertebral foramen. Do not operate it on the basis of the report, because if the report is wrong, our operation will fail. To such a positioning film before surgery, it is best to inject myelin blue on the spinous process as a positional mark after incision of the skin. Then, for patients with difficult positioning, I suggest a 3D print model can be made before surgery to help us. Worst is there no 3D print or cost of printing is considerable too high. I'm here to teach you a simple way. This is a male patient. Physical examination revealed a perivertebral tumor. We can locate tumor segments on MRI, CT using cross-contrast method just described. But you may not be able to immediately interpret this position as an actual situation. We can use a model of spine, use a piece of plasticine to squeeze a few close to the actual side of the tumor, and then place it in the corresponding position. Observing this model from various perspectives, stimulating the approximate scope of bone removal during surgery, mastering these anatomical structures, and then performing surgery. This is the CT after the operation. We can see the bone removal rate is just right. So the impact on the stability of the spine is small. For vascular disease, we also do DSA to identify the location of the fistula. In the AVF, the fistula is often located in the area where the nerve roots exists, the internal vertebral foramen. Sometimes we made the wrong positioning. How to remedy it? During the operation, we opened the dura according to the preoperative positioning and did not find a tumor or find that the positioning was wrong. What we need to do at this time is to determine where the accurate position is as soon as possible, because the bone has been destroyed at this time. So we need to do everything possible. More damage may be reduced. Do not blindly bet on whether to look up or down. Be sure to recombine the positional method before the operation very carefully to retake an X-ray film during the operation, and then pass the bottom section. The relationship between the segment and the normal segment is clear, and the location of the bottom segment is identified, and then enlarge the bone window. Generally speaking, if you can use these positioning methods I mentioned earlier, the error will not exceed one segment. The stability of spine needs to be re-evaluated to decide whether to do one-stage or two-stage internal fixation. In the next session, let's talk about the exposure of bone windows. First, let me introduce Dennis' three-pillar theory, which may be very familiar to everyone. We divided the spine into anterior, middle, and posterior column, of which posterior column and the middle column are the most important, include the posterior longitudinal ligament, vertebral annular, pedicle, ligament flavin, and so on. After understanding the three-pillar theory, all our exposure operation must follow a principle, which is called the principle of sufficiency. That is, enough is enough. Depending on where the tumor grows, as long as it is enough, try not to bite the segment that should not be bitten, and try not to bite the lateral joint. These redundant steps must be discarded. This requires us to have a precise positioning and a very clear 3D positioning of the relationship between the tumor and the spine. Let's take an example. This is a C1-2 tumor that communicates inside and outside spinal canal. Some of it grows into the subdural space in the spinal canal, and some grows out of the spinal canal through the intervertebral foramen. For such an operation, we have to make a very full judgment before the operation. How much bone should be bitten off? Therefore, we need to collect as much image data as possible before surgery, including MRI, CT bone, window, CTA, etc., and fuse these images together. The enlarged C1-2 intervertebral space can be seen on CT. Axial CT reconstruction can see the relationship between the tumor and enlarged C1-2 gap. We also doing 3D reconstruction image on the computer. We can see the relationship between the tumor and the posterior arch of C1, the relationship with the intervertebral foramen, the relationship with the vertebral artery, the relationship with the lateral vein, and which are very clear display. If you feel that such a three-dimensional image is still unclear, you can use the 3D printing method to make a 3D printing model and stimulate the range of bone windows that need to be exceeded during our operation on the printed model. We believe that a posterior median approach in this patient would be sufficient to expose the tumor in the spinal canal as long as a small portion of the posterior arch of C1 was removed. In practice, we carry out the operation according to this plan. This is the CT after the operation. It can be seen that the actual oculation scope of the C1 posterior arch is very small, and it does not exceed the posterior tubercular. So the impact on the stability of the spine is minimal. This patient did not require internal fixation after surgery. This is MRI after surgery. You can see that the tumor was removed very clearly. After the operation, we made 3D reconstruction image of the patient, which confirmed that the bone damage was very small. We bite off a part of posterior arch of C1 and did not operate on the ligament attached to C2. This case illustrates the importance of careful planning before surgery. The tumor was completely resected with minimal bone destruction. Now let's discuss one of the more popular techniques, hemilaminar surgery, or we call it hemilaminectomy. What are the indications for hemilaminectomy? I conclude that there are several situations. Tumors grow on one side. It is best to have an extramedullary or epidural tumor. If it is an intramedullary tumor, it is generally benign or grows on one side. The length and segment of the tumor are generally not limited. Hemilaminectomy is not suitable for all situations, and there are many technical issues that need to be addressed. First, its exposure range is relatively narrow, and the transverse diameter exposure is about 1.5 to 2 centimeters. So the space is relatively small, and the operation is relatively difficult. Certain difficulty arrives. In addition, it has been reported in the literature that this type of surgery is more likely to cause arachnoid adhesions and the foramen of the fibrotic callus around the scar, around the dura. After a period of time, the compression of the scar will cause new spinal stenosis. In addition, due to the lateral bite of the hemilamine, sometimes it will have a certain impact on the joints, and it will also cause a certain degree of instability to spinal sequence. Ligaments have less effect on the stability of the 3 columns just mentioned, but it is not without any effect on the stability of the spine. Let's look at this case. Is this suitable for hemilaminectomy? First of all, what is the diagnosis? I think the diagnosis should be an extramedullary subdural tumor. According to MRI, we judge that the tumor is mostly a cystic schwannoma, and its growth pattern is unilateral. Although the segment is relatively long, we think it is still suitable for hemilaminectomy. You can compare the indication mentioned above. In addition, the tumor is located at the cervical thoracic junction, and the segment is relatively long. If conventional four-laminar surgery is used, the stability of the spine will be affected for the stress point of the cervical thoracic joint. A very important instrument for hemilaminectomy is this dedicated separator. This is the photo after exposure. You may think that the tumor is small, but it is actually because we suck the cyst fluid to reduce the tumor volume. Because the exposed space is very small, it is difficult to suture the dura. Some doctors say in lecture or in the literature that such dura incisions are not sutured. and are directly sealed with artificial dura mater glue. Is this method possible? I think it can, but I personally don't recommend it. Why? Because the sealing of dura mater is a very critical fact for preventing the CSF leakage after the operation. The dura mater is a very critical fact for preventing the CSF leakage after the operation. The dura mater should be sutured situ as much as possible. I recommend that you use barbered suture for continuous sutures, which won't come loose during the stitching process. This is a photo after the dura is sutured. Now, let's talk about the protection of the spinal cord during spinal cord tumor resection. The importance of carefully manipulation is especially important for intramedullary tumors. The first is the incision of the spinal cord. We require strict incision in the posterior median sulcus. In some cases, such as cavernous angioma hemorrhage, the incision can also be made at the thinnest part of the spinal cord. For intramedullary tumors, some have a clear border with the spinal cord tissue, in which case the tumor can be completely resected along the border, such as ependymoma, cavernous angioma, hemangioblastoma. Some have no boundary with the spinal cord tissue. In such case, only intratumoral resection can be performed, and no forced separation is allowed. Otherwise, serious spinal cord function damage will occur, such as astrocytoma, lipoma, teratoma. For extramedullary tumors, because most of them are benign, it is relatively easy to separate the border. But some tumors that grow to the ventral side of the spinal cord are difficult, and the spinal cord needs to be rotated and displaced during the operation. Let's take some example below. This is a very typical patient with intramedullary ependymoma. On the left is the pre-operation film. On the right is the post-operation film. It can be seen that the boundary between the tumor and the normal spinal cord is relatively clear, and the surface of the spinal cord is smooth after resection, indicating good protection. Ependymoma is the most common intramedullary tumor, and I have compiled some surgical principles. First, most of ependymoma have clear border, and the tumor should be completely resected as much as possible. Second, the spinal cord must be incision at the posterior median sulcus. Third, the operation gesture should be kept parallel to the direction of the spinal tract as much as possible. Fourth, there is an enlargement of the central canal at each end of the tumor, and this can be used to separate the upper and the lower pole of the tumor. Fifth, the anterior spinal artery must be protected, especially when the tumor is isolated to the ventral side. This is a patient with an ultra-long segment intramedullary ependymoma, the tumor extending from the medulla oblongata to T2 level. Because the principles just mentioned are followed, the muscle strength of the patient after the operation is basically the same as that before the operation. This is also a special type of ependymoma that occurs in the cauda equina, called myxopapillary ependymoma. Sometimes it is not easy to differentiate from schwannoma of the cauda equina on MRI. During the operation, the tumor should be cut off from the place where the cone grows, and the boundary between the cone and the tumor should be separated. This is a patient with intramedullary glioblastoma. Glioma has no boundary with normal spinal cord tissue and can only be removed and decompressed with the tumor. This is a hemangioblastoma. Because it is benign, it has a clear boundary with the spinal cord tissue. A very important point is that you cannot get inside the tumor. Otherwise, it will cause uncontrolled bleeding. Intramedullary cavernous angioma with a layer of hemosiderin between the normal spinal cord tissue, it is a marker to separate the interface between the tumor and the spinal cord. This is a lipoma. Although a lipoma is a benign tumor, it is a hematoma and has characteristic of co-growing with the spinal cord tissue. It has no boundaries and it cannot be completely removed. Finally, mentioned relatively rare intramedullary schwannoma. We know that schwannomas mostly grow outside the spinal cord. A small number of schwannomas originate in the dorsal root entry zone, and the principles of management are the same as for benign intramedullary tumors. Okay, finally, we make a summary of today's lesson. First, there must be a suitable surgical plan before the operation. Before the operation and the skin incision precise positioning should be carried out to ensure the correct segment. According to the pre-operation plan, the minimum amount of bone is removed to achieve the principle of sufficient use. Different resection strategies are used for different types of tumors. Doing the above points well and forming a set of standardized surgical procedure can maximize the protection of spinal stability and spinal cord function. That is all my presentation. Thank you.
Excellent talk, and it was a brilliant talk for young. We should go about deciding what we call it. So basically what I'm saying is that I think it's an excellent talk and it's great for young neurosurgeons. Just give us a basic idea of how to select what kind of surgeries, what precautions we take, and how should we go about in dealing with our patients with multiple problems in which we're exposing bones. So I think from that perspective, everything is very clear. And thank you. It was very clear talk. But I have no questions on that.
Thank you.
Yeah. May I ask question, Professor?
Please.
Yeah, of course.
Professor Gu, I have two questions for you, Professor. I always find very difficult to make a localization, especially for a thoracic region. At this moment, at this era of modern era, I still depending on the II to identify the level. I find using the IGS system is very troublesome because you need to have putting the marker on the bone itself, spinal processes. So may I know that, do you have any trick that, or probably Professor Salman can also answer this question, any special trick that you can easily identify with the current new technology that you have in your OR? My second question, Professor, how often do you use the spinal cord monitoring, and do you use D-Wave? And how accurate, in your opinion, that this we offer to your patient in your surgery, and would it be medical legally wrong for any spinal or spinal cord surgery that you do not use intraoperative monitoring, Professor? Thank you.
Thank you. The first question is about the positioning. We have used two types of positioning. First is just in the surgeon room. we usually use the C-arm, just before we do the incision. And another type is before the operation, the day before the surgery, we use Melian blue, to inject on the spinal process. And the second question is about monitoring. And we use the MEP and SEP combined monitoring used in intramedullary surgery. When we do the intramedullary tumor, we use SEP and MEP monitoring, combined monitoring.
Professor, just probably Professor Salman, your experience, Professor?
Yeah, I think I agree. What we generally do is if it's a difficult level, we always get an X-ray pre-op so that we can know exactly what level is it. So we can correlate with our MRI or CT or whatever we have. And on the basis of the changes in the vertebra, you can decide which is the vertebra instead of counting levels and running into trouble. And that makes it life much easier with image. Otherwise, if it's a complicated level, then you can always use image guidance. And there's, if you're talking about lesions, obviously ultrasound could be used. Regarding monitoring, I totally agree. It's only used for intramedullary lesions. The only time I would use monitoring out of intramedullary lesions is somebody who's got very tight canal with myelopathy, and along with that, something like OYL and OPLL. I think that's where you could use monitoring as well.
Thank you. But I still find very difficult, Professor, by using the II, where you need to move the II along the spinal column, and sometimes you might miscalculate or miscount them, and especially when the cases when there's a lumbarization or sacralization of the segment, so that's become very difficult. Hopefully, we get something new in the future for this effort. I do not have any more questions. Dr. Harshad, our regular follower here, do you have any question from you, Dr. Harshad?
Yes.
Please
Whenever this marking problem is there, I use an MRI, and we are using this vitamin D capsule, or we use sometimes this nefidivine capsule over the skin and take an MRI exactly on a spinous process wherever the lesion is, whether it is a lumbar or a dorsal. The problem is more in a dorsal region, and we have faced it many times. If you miss the levels, and if you miss the levels, ultrasound is also not going to help us. So we use a skin marker there and then reconfirm on image intensifier. And I agree with Salman also, okay, we do X-rays pre-operatively and during surgery also. So pre-operative skin marking, especially in the dorsal region, is very, very important thing, needs to be confirmed.
Thank you, Dr. Harshad.
Thank you.
If there are no further question, I would call upon Professor Salman to give a concluding remark for the first session. Dr. Salman, Prof.
I think this was an excellent talk, and I think he summarized very nicely and very simply, and I think it was very, very clear. And I'm grateful that we could listen to his talk, and we could learn something new. And I agree with Harshad that putting in a nifedipine capsule is also worthwhile, just like doing image guidance when we don't have capsules or markers available. So yes, I think there are various ways of doing it. So but with experience, obviously everything comes and becomes simple. So that's the most important key.
Thank you to Professor Salman and our speaker, Professor Gu. And just for the information to all, we have about 690 audiences from all the 3 platforms, including a WeChat channel. Thank you, Professor. See you again, Professor. So we have our second speaker here, Professor Joshua Pedersen, and I would like to call upon Professor Benes to invite our speaker, Professor Benes.
Hello, everyone. It's a great pleasure for me to introduce Professor Pedersen from Mount Sinai, New York. He did his medical school at UCSF, California, and actually he did his residency there as well. Then, as I understand, you traveled through Ljubljana with Vinko Dolens, then on to Yashargil, to Zurich, and then on to Barrow Neurological in Phoenix, Arizona. I would say that that's probably was the best rotation at the time for vascular neurosurgery. And I must say that because I did exactly the same rotation between these three big names in neurosurgery. The Mount Sinai neurosurgery, which is chaired by Joshua Bederson, is top in many fields, and as far as I believe it's considered to be top 10 in the US, which means that it's at least top 20 in the world. I've met literally Professor Bederson at my early career because he was trying to produce a model of AV fistula. I did exactly the same. That was probably the influence of Robert Spetzler, because what I was doing was trying to make a model for normal perfusion pressure breakthrough, exactly the same way, suturing the common carotid artery to jugular vein, but downwards. You did it upwards, I believe. And I never was able to succeed. And the only publication we have from this is how to occlude the vertebral artery in a rabbit, which was fun because we tried to get more ischemia, chronic ischemia for the brain, but never really succeeded. I believe that today we shall learn a lot, much more than from one single shunting procedure in a rat. And Joshua, please go ahead with your lecture. I have forgotten one important thing. Professor Bederson is smart enough to cover all neurosurgery in Mount Sinai, since his first international travel to Europe was to Italy, as I understand. And he met his wife, who is Professor Isabel Germano. And in a way, they have both covered. Joshua is moving more outside the brain, it means vascular, and Isabel is moving more inside the brain, like gliomas and all the stem cell business and all the regeneration. So please, Joshua, sorry for delaying you.
Thank you so much. It's a beautiful introduction, and it's a pleasure to see you again, as well as an honor to be here to speak. And I hope now you can see what we're going to talk about: innovation in neurosurgery through advanced technology and a program called Sinai Biodesign. My disclosures, as you can see here. Just a little bit about Mount Sinai Hospital. It was founded in the 1800s, and it has slowly grown over time. Its location on Fifth Avenue, New York City. You can see its location here relative to Central Park. This is Madison Avenue, Fifth Avenue. And over time, the hospital has grown substantially. You can see even since I've been there, new buildings are popping up all the time as a consolidation of healthcare systems has occurred in my country. Some of the major hospitals have grown substantially. Currently, Mount Sinai has 43,000 employees, making it Manhattan's largest private employer. To give you a sense of scale, Delta Airlines before the pandemic had 80,000 employees. So you can see that in addition to being a hospital, it's really now a large corporate enterprise that is a significant influence in New York City. The neurosurgery department was founded in 1914, making it one of the older departments in North America. And I'm the 8th person to be a chair of the department. It's a fairly large faculty with about 30 to 40 people. Is it possible to mute? Thank you. It's a large program, and we have a large number of advanced practice practitioners, physician's assistants, and nurse practitioners. Our case volume is approximately 5,000 to 6,000. Here you can see the impact of the pandemic. This slide is slightly old. Right now, we're projecting about 5,500 cases. And we try to cover all of the different categories of neurosurgery. These are our divisions. We have focused also on developing our research programs. Right now, for NIH funding, we are number 20 in the United States for NIH research funding, but we're number 1 in New York State and New York City as our research footprint has grown. Today, I'm going to speak about instrumentation, how instrumentation in surgery, and particularly in neurosurgery, has advanced through the years. Surgery is in itself always based somehow, in some way, on instrumentation. And as you can see, the instruments that surgeons have used, although they may seem somewhat outdated when we look back, are always elegant. They're always maybe at the forefront of craft, of science and art. And even something as simple as these Stone Age bronze tools would have been at the peak of technological development in their own time. And in neurosurgery, we've progressed from trephination to stereotactic guidance to computer-aided guidance and beyond. I had a chance to write a paper in Science about innovations in surgery, collaborating with cardiac and other surgeons here. And in trying to summarize what are the things that really is a challenge in neurosurgery, I focused on the concept that blood is red and we can't see through it. Tissues are opaque. Bone is hard, brain is soft. And some of the basic design features of the human body and the brain really make it challenging to operate. And I'll get to a case like this one where we apply our most advanced technology. But the basic factor is that even though we know the anatomy, such as in this simple clinoidal meningioma, hiding the optic nerve, the carotid artery, optic nerve, carotid artery, and the oculomotor nerve. When we first open, we don't see those tissues. We don't see those structures because they're hidden by the tumor. To me, this process is similar to one that the sculptor uses, in which we envision the beautiful anatomy that is obscured by a tumor or something we don't want. And our job as surgeons is to remove what is not necessary. Which brings me to virtual and augmented reality in neurosurgery. I'm sure that many of you are aware that in virtual reality, there is no interaction with the real world, whereas in augmented reality, we overlay our virtual reality into the actual field. In neurosurgery, simulation is helpful for planning. Navigation gets you where you want to be, and augmented reality helps you do it better. The steps, as you may know, are to first create a simulation. Think of the movie Avatar, but we create a simulation by combining our different modalities into a virtual reality scenario. We link that virtual reality scenario to the anatomy. Think of the GPS for our car. And then in the case of a heads-up display, we project some of that virtual reality onto a map of the brain, just like we might do in aviation, projecting a runway onto the actual runway. The workflow for augmented reality is that we first prepare for the surgery by obtaining images, defining the volumes of interest, and then to select critical structures that we're going to use for navigation. We then plan our surgical approach and then link our microscope, endoscope, or exoscope to the navigation, inject the image into our microscope or endoscope, and then as the case progresses, we may need to re-register during the surgery. There are many different uses of mixed reality, from patient consultation all the way through the many phases of surgery. For patient consultations, it can be very useful to translate the original images, which you see on the top here, to these enhanced images. We create simulation-based, patient-specific scenarios and go over these with the families. And sometimes, if we've not had a chance to create a virtual reality scenario based on that patient's individual case, we have a library of cases that are quite similar and can show them the virtual reality of a different patient. For surgical planning, I will give you an example. This is a 71-year-old man who presents with ataxia and has this foramen magnum meningioma. We can use different types of software, and here you see the BrainLab software. And the BrainLab software is quite useful. It does its own type of segmentation, and this is useful to plan the operation. We can see the tumor in relationship to the brainstem and the other critical structures. There are other softwares, and here you see surgical theaters, which is slightly more advanced in some ways. And here we have outlined bone, tumor, and blood vessel. And so in identifying this, we can plan our approach. And here we now overlay the cervicomedullary junction. And so this is how we plan for our surgical approach. As part of planning, we can also predict the extent of tumor resection. And we have used this to revisit the NOSP criteria for pituitary adenomas recently. And so what we have done is a volumetric analysis of pituitary adenomas and compared the extent of resection using a volumetric analysis versus the NOSP criteria. And over here, you see the NOSP model. And you see that using a volumetric analysis, we have a slightly more sensitive way to detect and to predict the extent of tumor resection. So this is all part of the planning process, using virtual reality to enhance our ability to plan. For intraoperative use, as you can see, the surgeon has many different types of information available to him as he operates. In the beginning of this procedure, we use heads-up display to design a skin incision. So what you're seeing on this top right is a small cavernous angioma. This purple dot here is what is seen by the surgeon as he looks through the eyepieces of the microscope, helping us design a skin incision. Once the scalp incision is done, And here you see on the top right, the same small cavernous malformation. So from here on the top right, you see the cavernous malformation projected on the skin. After the scalp has been opened, this is the same projection through the operating microscope, showing where we expect to find the lesion. On the left, we have a much larger lesion, and so you see the use in two cases. This is a large tumor. Once we, it's on the opposite side in a different patient. Once we have the scalp reflected, we see exactly where that's going to be to help design our craniotomy, as well as the dural opening. This is a 47-year-old female presenting with cerebellar findings and this very large tumor. When we open, we have selected out just the tumor. This red is the 7th nerve where we expect to find her facial nerve, and you see a faint outline of the basilar artery. This gives us an idea of the extent of resection that we will need to achieve. As the tumor dissection progresses, we see that this tumor extends way up underneath the cerebellum. And so we'll have to achieve a different angle to get way back there. But over here, posteriorly, we see that we're already at the tumor's edge. When we finally have gone very deep, the red is the projection of the facial nerve. And you can see that within a millimeter or two, it's quite accurate, as confirmed by the handheld stimulator. And then at the end, we see the final result. And then a gradual return towards baseline with an intact face in this patient who happens to be a celebrity. Here I'm going to show you a video that I hope describes this process.
We present the case of a 45-year-old woman.
Do you hear the video? Do you hear the sound, by the way? Can someone confirm that you hear the sound?
Yes, Prof.
With the right clinoid meningioma diagnosed incidentally after a head trauma. Her neurological exam was normal at the time of presentation. The tumor was extending from the paracellular and cellular regions to the middle and posterior fossa. A CTA was obtained to further characterize the intracranial arteries encased and displaced by the tumor. A preoperative angiogram was conducted 2 days before surgery to devascularize the lesion and reduce intraoperative blood loss. The inferolateral and meningohypophyseal trunks were coiled, resulting in reduction of tumor blush. Note the fetal origin of the right posterior cerebral artery. After the procedure, the patient experienced right partial third nerve palsy. 3-dimensional simulation allows neurosurgeons in training to explore the different operative angles, as well as to plan the bone opening while using the virtual reality goggles. Here, we can see in close detail how the tumor was encasing the internal carotid artery terminus, the origin of the anterior and middle cerebral arteries, as well as the posterior communicating and anterior choroidal arteries. The basilar and superior cerebellar arteries were in close contact with the posterior medial aspect of the tumor and laterally displaced. This 3D virtual model of the patient's specific anatomy can also be integrated with the navigation information intraoperatively to assist during surgical resection. The images of the CT angiography and MRI DICOM series were fused to co-register scans for preoperative planning and intraoperative navigation. Preoperative planning software allows for segmentation and 3D reconstruction of the tumor and critical neurovascular structures using the Smart Brush tool on the MRI or CT imaging. The segmented neurovascular objects can be highlighted in specific colors. Here, among others, we have segmented the tumor in purple, the internal carotid and middle cerebral arteries in pink, the posterior communicating artery in blue, optic nerves in yellow, and the brainstem in green. This information can then be registered via navigation and displayed in the eyepiece of the microscope in an augmented reality fashion to optimize surgery workflow and avoid having to redirect attention to the navigation screen. The objects can be turned on and off during surgery to draw attention to specific structures intraoperatively and also limit attention blindness. The heads-up display has potential value during multiple stages of surgery, from as early as planning the skin incision to craniotomy design or dural opening. The microscope can be brought to the field to superimpose the tumor object over the patient's anatomy and confirm appropriate size of the pterional craniotomy. The dura was opened in a C shape and reflected anteriorly. When opening the basal cistern, special care must be taken to identify and preserve the superior-medially displaced optic nerve, which can be seen outlined in yellow in the heads-up display before it becomes visible. While we continue to split the sylvian fissure and advance in the subarachnoid dissection to access the tumor, we have changed the heads-up display visualization from 3D to 2D. The augmented reality can be seen as distracting and interferes with the visualization of the surgical field. However, over time and with practice, the optimized number of segmented structures can be easily be integrated with the anatomic visual information. Here we have specifically outlined the optic nerves, the internal carotid artery, the middle cerebral artery branches, and the tumor. We start by carefully dissecting the tumor away from the branches of the middle cerebral artery. There is a superior and posterior offset of the heads-up display relatively to the patient's anatomy. The current software allows us to update the heads-up display information intraoperatively, but given that in this case there is just 1 or 2 millimeters of difference, it is not necessary to adjust it. Note that the solid lines represent the portions of the middle cerebral artery with the current focal depth of the microscope, whereas the portions in the deeper plane are outlined in dots. By confirming that the objects displayed correspond with the patient's anatomy, we have confidence that the information provided by the heads-up display is accurate. After careful retraction of the frontal lobe, we visualize the lenticulate striate arteries, which limit access to the medial aspect of the tumor. Therefore, attention is taken to approach the tumor in its most anterior lateral aspect. At this point, a cortical grid was placed over the motor cortex to obtain continuous monitoring from the left side of the body. Transcranial motor and somatosensory evoked potentials were also monitored bilaterally since the beginning of the surgery. After gaining inferior access to the most anterior lateral aspect of the tumor, we dissect the tumor away from the middle cranial fossa floor. Here again, the solid line represents the portion of the tumor with the same focal depth of the microscope, whereas the tumor that is deeper to the plane of dissection is outlined in dots. Providing constant awareness on how much further we have to go continues as part of the dissection. The sonopet is combined here with a bipolar to facilitate tumor debulking. We can see how this part of the tumor is relatively avascular thanks to the preoperative embolization. The anterolateral aspect of the tumor has been debulked, and now we're progressing the dissection towards its superior posterior aspect and delivering it anteriorly into the expanded sylvian fissure. Again, we use our bipolar to dissect the tumor capsule and ultimately the sonopet to debulk the tumor. Here, we take the advantage of the heads-up display to early identify the internal carotid artery on the left side of the surgical field. In addition, given that the lateral aspect of the tumor is underneath the temporal lobe, the heads-up display is also helpful to provide awareness of the lateral border of the tumor. Here, we see the origin of the posterior communicating artery entering into the tumor. Just distal to the posterior communicating artery, it is the origin of the anterior choroidal artery medial to the section tip. Those arteries are protected with a conoid, and further work is done on the tumor lateral to them. At this point, it is necessary to identify the posterior communicating and the anterior choroidal arteries as they exit the tumor posteriorly. The heads-up display here outlined in blue is critical in order to provide situational awareness for the surgeon to identify these structures before seeing them with a microscope. This moment is one of the most important of the case since it is essential to preserve these arteries given the crucial anatomical brain areas they supply and the fetal origin of the right posterior cerebral artery. We confirm the patency of the vessels using the Doppler. After confirming the vessels, just as we did anteriorly, we will now focus the remainder of the resection lateral to those vessels. Here we identify the superior cerebellar artery in the perimesencephalic cistern, medial and beneath the tentorium. This demonstrates, again, the efficacy of the preoperative embolization in creating relatively avascular tumor tissue. The consistency of this portion of the tumor is, however, more fibrotic than its most anterior aspect, and the use of the bipolar is needed to coagulate and detach tumor pieces. Here we can see the fourth nerve in the ambient cistern, just beneath the free edge of the tentorium. With the superior cerebellar artery now protected underneath the conoid, we can see here branches of the anterior inferior cerebellar artery. Over the left, we can see how the posterior cerebral artery correlates with the integrated navigation screen with a microscope trajectory in blue. By following the dissection medially and inferiorly to the posterior cerebral artery, we identify the basilar artery and dissect it from the tumor. In this final stage of the surgery, we're decompressing the brainstem by removing the last portion of the tumor in the posterior fossa accessible through this approach. We can see in the heads-up display how the posterior communicating artery delineates the medial limit of our tumor resection. Endoscope-assisted microsurgery complements traditional microsurgery in the management of complex skull-based tumors. The ability to attach the endoscope to the microscope makes it easier to combine both techniques. In this endoscopic view of the posterior fossa, we can see the preserved fourth nerve underneath the tentorium with some expected residual tumor. The postoperative MRI demonstrated decompression of the brainstem with expected residual tumor medial to the posterior communicating and lenticular striate arteries. No neurological deficits were noted after the surgical procedure.
I feel I should probably apologize for such a long video, but I think that this describes the use of heads-up display and augmented reality better than I could probably do on my own. And I thank my colleagues for helping me with this case. We're getting near the end of the time that I have, and I wanted to just go over one other concept of intraoperative navigation update. And here what you could see during an approach, and this is a right retrosigmoid approach, you see that the craniectomy has been done, and the heads-up display shows the transverse sinus transitioning into the sigmoid sinus, but it's in the wrong position. It's displaced posteriorly and also a little inferiorly. So what we can do is stop the operation and go back to the software and move the heads-up display in the direction of this yellow arrow to now position the augmented reality appropriately with the anatomy we see, thereby giving us greater reliability. In the final slides, I wanted to just mention that we have at Mount Sinai really focused our efforts on advanced technologies. And we have created something called Sinai Biodesign. In Sinai Biodesign, which is a medical device incubator, we partner with our medical transfer service and interact with the clinicians to produce new companies. And over the past several years, we have engaged faculty to create new concepts, new ideas, commercial licensing agreements, and new companies such as Chill, which is a new catheter to cool the brain, and many others. So what I didn't really have a chance to describe this in great detail. I'm skipping through the slides in order to make sure that we're done in time. So I'm not really able to describe the full program. But the idea is that over time, in using so much advanced technology, we have realized that we can develop our own devices within Mount Sinai because we have engineering capabilities, rapid prototyping capabilities, and of course, the large clinical volume. So I'm hoping that what I presented today is just the beginning of a long series of new technologies that we can deploy in the service of improving care. So I'll thank you. I'll stop there and hope we have time for a couple of questions about augmented reality and heads-up display in neurosurgery. Thank you.
Thank you very much. That was like future or science fiction in some points. I just wonder, what is the limit of recognition? Like anterior choroidal artery, are you able to get these tiny structures like perforators anterior choroidal into your heads-up display?
That's a great question. About 1 millimeter. And so perforators know in this particular case, I'm not sure that was the real anterior choroidal artery or whether it was a PCOM artery that was a little larger that was running parallel to the anterior choroidal artery. But for vascular structures, we can navigate down to about 1 millimeter in size. So crucial perforators that are coming off the PCOM, for example, or the back of the basilar, we cannot. Likewise, I showed you a case where we were able to visualize the 7th nerve. That's because that was a choroidal tumor, not a vestibular schwannoma. If that had been an acoustic neuroma and the nerve had been flattened, I don't think we could visualize it. So we're still running up against the limits of imaging.
I see. So in a way, it's like, I would call it the augmented experience, because you still need your experience, and this is just augmenting all this your lifelong experience, right?
Yeah, I've never used that term before, but I think that that's perfect. Augmented experience is really closer to what we're getting at than augmented reality. That's exactly right. We're trying to, we are all limited by these very basic facts that blood and tumor and brain are opaque and we cannot see through them. And so we're trying to enhance our powers. One really interesting concept is that right now, all the feedback that we receive from these tools is visual feedback. I believe we could in the future link other types of feedback besides visual feedback, such as haptic feedback. So if we could attach some sort of vibration device or resistant device or electromagnetic, instead of seeing the artery, we can feel it. And that might further augment our experience. But you're right, experience is a beautiful way. I hope you don't mind if I steal that.
And one last point before we shall get to any other questions. In fact, you have surgical anatomy, patient-oriented and individualized anatomy. It's not like those beautiful books like Rotten, the Bible. You got really where the structures are moved, where they are shifted.
Yes.
So you and how frequent do you have to adjust for the movement during the tumor resection, for instance, when the structures move?
Well, I think this is more useful for as you started with your introduction, this sort of surgery is in many ways outside the brain, as you pointed out. And those structures, and so those structures do not move as much as the intrinsic internal structures. So I don't think this is quite as useful for intrinsic tumors. But the skull-based lesions are relatively fixed. And so usually the only adjustment I have to make is in the beginning, when I first orient myself, where's the transverse sinus, where's the edge of the tumor, where's the optic nerve? Often when I reach the optic nerve, I stop, and then I readjust. It can be in the XY axis, up, down, twisted, or deep. And so we make one adjustment usually, and that's all I have to do.
Okay, thank you. Are there other questions from the audience, please? Or remarks?
Professor, may I ask some question? Hello?
Yes, sure.
Yeah. Thanks for a very interesting and nice presentation. I have 3 questions for you, Professor. Regarding, for example, the sphenoid wing meningioma, would it be able for us to identify which vessel are feeding vessel and which are the passive vessel which we need? Because the usual way is we follow the vessel until we see whether it's a tumor vessel. Will that software help us to solve this problem? My second question, Professor, regarding basal ganglia bit, where we do a stereotaxy aspiration with the augmented reality, which show the actual size of the clot. While if do you have a system when you aspirate the amount of whatever volume that coming out from the aspiration, be able to show adjusted size of hematoma, for example, in your augmented reality images. My last question, Professor, regarding the warning system, whether you have a built-in warning system to tell us how close of identify vital structure. For example, in CP angle, we have identified facial nerve and vital structure. So how far are you? Would it be a warning system telling us you are 5 millimeter or 4 millimeter away from it? Thank you, Professor.
These are fantastic questions. I think you have just identified all of the cutting edge areas for, I would call them opportunities. And you've covered almost the whole field. And the answer basically to all your questions is no. We don't have, so you asked, can we distinguish feeding from vessels of passage? In some way we can. As you may have seen in the video, we did a preoperative embolization for feeding vessels only and identified feeding vessel versus vessel of passage. Because we have DICOM images, we can now navigate off the angiogram. So in that particular case, the answer is yes, we can identify feeding vessels and navigate to the feeding vessels. However, we did not need to because we embolized those feeding vessels. So in the case of the video, we treated every vessel as a vessel of passage. If we have not embolized, then we can navigate to the vessel that we would like to embolize, but maybe we cannot embolize it because it's also feeding the optic nerve, the retinal artery or something like that. So in those cases, we can. So that's the only question you asked that I can say yes to. The next question is for the volumetric removal. We do not yet have a way other than intraoperative imaging of calculating that. And now we do have an intraoperative CT. We're using catheter-based ultrasound now. So we can estimate, and of course we can measure what we have removed, but that's imprecise because sometimes there's bleeding and irrigation that comes in. So the answer to your second question is no, we do not have a good way of doing it, except that using our new techniques of volumetric aspiration, we are using an endoscope and irrigating saline continuously so that we can see the cavity collapsing and we know when we've reached the end. And we have about an 85% removal of hematomas on average. And your last question is the one that is most interesting to me, the so-called warning system. Right now, as I mentioned, our only warning is the visualization of the instrument relative to the vessel or the brainstem. We are discussing now 2 different types of warning system, 3 actually. One is that as you get closer, the color will change or the opacity will change. So right now we use either a dotted line or an outline. And it should be possible, it is possible as we get within 5 millimeters. Now that becomes brighter or more solid. The second one is a sound. It is possible that we could, for each vessel, carotid, middle cerebral, tumor, brainstem, nerve, have a different sound that when we get close, we hear that sound. So now we're in discussion trying to develop these. But I'm very interested in the warning because sometimes you get caught up in what you're doing and you forget that you're near something. And so it would be quite helpful. Thank you for those great questions.
Thank you. Thank you for the great lecture, Professor.
Be like a music of the humor.
Yes.
Any other question from the floor?
There's one question in the chat box, Professor, by Dr. Harshat. She asking what is the fallacies of this augmented reality, Professor?
The what? What is the which?
The fallacies. The
fallacies?
Yeah, fallacies, yes.
You meaning the pitfalls and where what are the biggest problems?
Yes, possible, yes.
The biggest, there's one, thank you for the question. The biggest problem is the deep surface interface, what I call the DSI. So augmented reality heads-up display is very effective in the X-Y axis. The Z-axis is the most difficult to experience, to use Dr. Benez's word. As we get deep, it is very difficult to represent that visually. The whole purpose of heads-up display is that you don't have to constantly stop what you're doing and go look at the navigation screen. That is a very disruptive moment when you're doing a big, difficult case like this. And the biggest weakness or fallacy of the heads-up display and integration is that we're not able to visualize that deep surface interface where the tumor ends and the brainstem begins, or the optic nerve or the carotid and so on. It's related to your question about warning systems. So right now, this is the biggest weakness, and I hope that we have answers, technological solutions for this over the next 5 years or so.
Thank you.
Do I understand well that you are doing your surgery using a regular microscope?
Yes.
Right.
And
it's augmented reality. Do you have it like a image in image, or do you have it overlaid in your vision?
Yes, overlaid. It's overlaid in the eyepieces. I do have a slide that I think demonstrates that. I could try to locate that slide, but it might take me a minute to do so. Yeah. So we use a Zeiss latest model microscope, which has in its eyepieces the ability to inject video, but it is not a picture-in-picture. A picture-in-picture is a static picture that is getting in your way, usually on the periphery of the visual field. Here we're taking just a portion of the navigated objects and injecting those into the eyepieces so that you see both as you're looking through the eyepieces.
Very good. You know, there was a rather big move between the microscope and exoscope, which gives you a little wider field, little deeper field, and which is much more flexible than the scope. What I would admire is to have like a heads-up exoscope that you wouldn't need any instrument there. Are you working or something like that?
Yes, yes, we're working with Synaptive. We have the Synaptive exoscope, and what's quite interesting is that Synaptive software focuses on DTI and tractography. So we have heads-up display with the exoscope for tractography, but we do not have very good blood vessels, tumor, and so on. And that's because it's two different technologies. But you're absolutely right we have optical information from the microscope and video information from the heads-up display. Wouldn't it be better if we had video in video, which is what the exoscope actually gives you? So theoretically, the exoscope should be better suited to this type of technology, as you seem to be implying. But yeah, we are definitely working on that.
Okay. Well, really amazing. Thank you very much for the great lecture and really some future of neurosurgery be given to us all. If there are no other questions or remarks, I would thank you and give word back to Boonseng. Will you?
Okay, thank you, Prof. Thank you for Prof. Benison for the nice, exciting, cutting edge technology, and hopefully we can have it be in the market soon. And thanks, Professor Benes, for chairing this session. We have a wonderful discussion, and I think we are at the end of the today webinar. And on behalf of the Education Committee of the ACNS and the President, Professor Yoko Kato, I would like to thank both speakers of today, Professor Joshua Bedison and Professor Gu Shizin, as well as our chair, Professor Vladimir Benes and Professor Salman Sharif for the time and support for the ACNS webinar. I would like also express my sincere gratitude to Professor Zubin for broadcasting this webinar on WeChat channel. And today we have around 690 people who join us live from all three platforms. So until we meet again next Wednesday, it's a bye-bye from all of us. Thank you for joining. Thank you, Professor.